Hello, we're here in Scottsdale, Arizona at the TED conference. We're here with Dr. Rick Jacoby, and we're going to answer some questions about the connections between sugar and cardiovascular disease. So, Rick, that's the first question. Tell us about the connection between sugar and cardiovascular disease.
Well, there's a lot, and thank you for inviting me to this conference. Podiatry and sugar and cardiovascular disease are all one thing, basically. Sugar causes the inflammation of the lining of the blood vessel. Cholesterol sticks to that lining. That's what atherosclerosis is. And that's the connection between podiatry, peripheral vascular disease, and peripheral neuropathy. So these are all intertwined. That's why I'm here. TED is basically for Ted Dietrich. He started this industry in Arizona. I'm pleased to be here.
Cool, glad to have you. So tell us about I know you mentioned you're releasing a new book. We know everyone knows your first book, Sugar Crush, has been really successful. Tell us about your new book, Unglued.
Well, that's an exciting project. It's kind of got delayed the last couple months because I'm finishing up the FDA portion of what stem cells are, and that's a new thing. But the basics of the book is, and why it's called Unglued, because glucose, which is glue in Greek, and that's how this disease starts. It gums up the work, so to speak, for the artery, nerve, and vein. So Unglued will take us through all the technologies, all the pathology that is at this seminar, and devices that can clean out the artery, fix the artery, things that can prevent this disease in a much non-invasive pathology. This is an amazing conference.
Cool. I saw you walking the conference. There are a lot of vendors, a lot of really interesting innovations. Tell us about the innovations that you think are really impactful.
Well, I think it's just like the iPhone. That's what it is. It's cheaper, smaller, faster to the same technology. So diagnosing this disease is very simple, minimally invasive. That's an important point. And when you need to clean the artery out, it's now done in an outpatient setting, not in the hospital. A magnitude cheaper, no pain, in and out procedure, same day. The technology is here. That is here is game changer.
That's great. Well, thanks.
Yeah. Quite an innovation and a great day here in downtown Paradise Valley.
Well, thanks for joining us for this interview with Dr. Rick Jacoby, and thanks for joining us at the TED conference.
Thanks for joining us. I'm Rob McNutt with Endologics LLC, and today we have a fantastic guest. Go ahead and introduce yourself.
Thank you, Rob. So Rob used to be our tech when I was at Arizona Heart Hospital. So super pumped to be here.
Yeah,
thank you. I'm a vascular surgeon. My name is Sonia Noor. I'm at Buffalo General Medical Center. I'm the director there. And then we also have an OBL that I work at.
So, Dr. Noor, I know that you are really involved with new technologies. I think because of your association with Arizona Heart, there's always been innovation kind of in your blood and stuff. And at Endologics, we've kind of tried to innovate where we've moved to a polymer-based graft as our primary device, and I believe you use a lot of that, so we'll talk about that in a different segment. But one of the therapies that we're really excited about is this PTAB, which is that percutaneous transmural arterial bypass. And so how much experience do you have with that? Were you a part of the study? Talk to us a little bit about that, please.
Yeah. So no, I wasn't part of the study. Have had experience with PTAB. We've done a couple of cases. So my take on PTAB, which I hate the name like Venki does, So let's call it percutaneous bypass. I think is a great solution to a lot of our PAD patients. I think PAD is on the rise.
Yes.
There's no way that patients are going to stop being
It's progressive.
right. And there's between diabetes and being overweight and smoking, I think it's only going to increase. So the procedures that are being done now across the country are either OBL or outpatient cath lab and some ASC. And I think it's multi-specialty, so it's a mixed bag of people who are performing those procedures. But everybody at some point has done enough where now they think, okay, the next step's going to have to be a bypass,
Yes.
which is a big, complicated procedure for a lot of these elderly, sicker patients. So I think that's where, for me, starting out, PTAB fits. So that's a great solution to multiple endovascular procedures that have failed. Now you need to go for the bypass, but you're too frail perhaps for the bypass, or you want a better solution than a bypass so you can get back on your feet. So I think it fits perfectly in that kind of patient.
So it almost gets niched into that failed PAD wire-based procedures.
Right.
Instead of getting a scalpel or whatever, this is your next step, possibly.
Right. So if I think of it, if I'm an interventional cardiologist or I'm an interventional radiologist, when I get to that point,
Yeah.
I have to send it to the vascular surgeon.
Yes.
Right? This allows me to not have to do that. I have to have a relationship with the hospital, which
Yeah.
I think isn't such a bad thing. I think docs should think about coming back to the hospital and finding a way to make it work. And then those patients will have the benefit of not having to go to a different system, to a different physician. I feel more collaborative things will happen between vascular surgery, interventional cardiology, interventional radiology, because maybe we can help each other do the procedure.
Agreed. So we received breakthrough technology with this for the FDA. We were super excited. It was approved in June of 2023, and we're really rolling this out slow. You were part of the original rollout.
Yeah.
It has to do with, we look at volume of the patients, volumes that the facility has.
Sure. Yeah.
We also look at the skill set of a doctor. And so you're highly skilled. Let me ask you how easy you think it is to do PTAB. Now, in saying that, I want you to realize that I know that you have a lot of skills and you use a lot of different devices and stuff, but can this translate to somebody that does not have the skill set that you have?
I think that's where collaboration with the specialties will actually be a good thing.
Yeah.
Because I think there are some vascular surgeons whose endovascular skills are perhaps not as good as interventional cardiology or interventional radiology is. And here's a great place to collaborate.
Yes.
So between the two, you definitely can make this, you'll have more experience, you can get it done. If you have advanced PAD skills, this is not a difficult procedure. Every procedure can be challenging. You have to troubleshoot, you have to plan, you have to think about things that you need to do and how you're going to overcome those things. But essentially, starting out, it's a little bit of a longer procedure than I would like, because all of us have ADHD and we want to be done in half an hour. But I think you could get it down to a comfortable working length. And then the solution you're offering to the patient is so far superior that it's worth us investing a little bit of time and radiation, to get this case done and give the patient the benefit.
So a couple other things. One is, Endologics received, I don't know if it was the fastest, but it was really rapid, where CMS actually has add-on reimbursement for both inpatient and within a hospital outpatient setting, so TPT and NTAP.
Yeah.
And so really what it was, I think CMS was trying to remove that financial barrier for that. Would you consider doing within a hospital an outpatient FEMPOP bypass?
So, when you look at CMS's reaction to PTAB, it's very interesting, like you said.
Yeah.
Not only did they approve a new therapy, so it's not a new device really, it's a new therapy.
A new therapy.
They gave you both inpatient reimbursement that supports it, and they gave you outpatient TPT in the, just with one overnight stay. So what's the difference? 2 night stays versus 1 night stays. And it allowed you to do it with a financially viable model for the hospital to do both. I don't think that's ever happened before, right? So CMS believes in this new therapy. Now we just have to have enough users to do it. So the other hurdle that we didn't talk about is the VAT, right? Getting it into the hospital. And this allowed us to get it into the hospital a lot quicker. And frankly, that can be a huge stumbling block. Like, you can buy into the technology, you can go get trained, but if you don't have it on your shelf, what good is that? It takes you a year and a half to get it. That's reality. That's what's happening to a lot of our colleagues. So the fact that CMS made it easier you can get it into the system and you can do it. I think once you work in an OBL ASC system, your mindset is different. You anticipate problems, you see problems, you do a better job kind of forecasting how your patient's going to do down the road. And there's no reason in a otherwise straightforward PTAB, you book it as an outpatient,
Yes.
potentially ready to discharge them the next day. If they're not, so they stay one more night.
Yes.
You change it to an inpatient, like nothing really changes. But I think as we get better and better, most patients are going to go home the next day.
So I see, I mean, you're a vascular surgeon, so you're probably used to, not in your OBL setting, because there you're used to conscious sedation, but within a hospital, you're used to general anesthesia, maybe even a Foley catheter or something like that.
Yeah.
I don't know if you're aware of this, but 60% of the patients in the study were done conscious sedation.
Yeah.
Would you consider conscious sedation for this procedure?
Yeah, not right away. And the reason is I like to be very deliberate and think through everything that I'm doing. So the first, and we're a training center, we train the residents and fellows, which I
Yes.
love to include them with our new technologies. So I'm a little bit of a hybrid, even though I'm a private practice physician. I work in an OBL a day and a half of the week. The rest of the time, I'm really at the hospital.
Yes.
So doing the other open cases. So I wouldn't do that initially. That's basically how I've done everything that I've done, whether it was TCARs, for example. We started with general anesthetic. I just think it takes out, the patient tolerates it better. It takes out that extra level of stress, both for you and for the patient. You have a little bit more time to be deliberate and think about it. But certainly as time goes on, we've been in the OBL 10 years. We started with diagnostics and access only. Yes. And now we probably do more complicated cases in the OBL with conscious sedation, pedal access than we do in the hospital. So it's just a learning curve. I think as I get more comfortable, I can see us doing it with conscious sedation.
I appreciate it. So we don't want to take up all of your time. I know that you have a flight to catch and everything.
Yes, thank you.
So in saying that, I just want to thank you for being an innovator.
Thank you for training me.
I don't know if I did that.
I know you did.
But I think TED Conference in general really looks at new technologies. They really are data driven.
Sure.
And I think that ask your local Endologics rep, talk to Dr. Noor because she's an expert, and get some ideas about whether this would fit into another person's practice or whatever. Yeah. And if you have any final words, I'd love to hear them.
No,
words
thank
of
you.
wisdom.
No, thank you. Thank you for doing this, and I'm excited about this technology for our patients.
Yeah.
I think it's going to be a really good solution for very, very difficult patients sometime. So thank you.
We love partnering with you.
Thank
You're
you, Rob.
amazing. Thank you
Appreciate
so
it.
much.
Thank you.